Morning, everyone. How are you guys today? Well, thanks for coming. It's my pleasure this morning to introduce Adesanya, who is here to give a talk on reimagining secondary prevention using telehealth. And I had the good fortune of meeting Ade actually back in November. He and I both gave a talk at an AHA, American Heart Association symposium on telehealth. And I was really impressed and kind of blown away by some of the work that he's doing. And so I asked him to come and kind of update us on what they're seeing in terms of how to use telehealth and how to use that specifically for cardiac rehab. So Ade is the co-founder of Moving Analytics, which is a digital health company that helps hospitals implement home-based post-acute care management programs for patients with cardiac or cardiopulmonary disease. They've implemented these programs at places like the Mayo Clinic and NYU, as well as the VA system. Ade, welcome.
Okay. Awesome. So thank you, Mark, for that introduction, and it's to be in front of all of you today. So while I was preparing for this talk, I was on CNN this morning, and I thought I share some news I read that may be applicable to you. So I'm going to read the paraphrase. So the president said, we have a new crisis, and it says heart disease is killing more people globally and in the US than ISIS, radical Islamic terrorists, and it's killing our youth higher than ever before and our loved ones. And we must make America great again, and we must build a great wall of primary and secondary prevention programs to keep away heart disease, diabetes, and heart attacks. Now, obviously, those are alternative facts, and I thought it would be nice to share. Well, my talk today will really talk about how we can promote, and prevent cardiovascular disease, mainly through using telehealth. So to give a quick background of myself, I grew up in Lagos, Nigeria, and I came to the US to study electrical engineering, I think 10 years ago. And during my undergraduate studies at the University of Houston, I dabbled into the entrepreneurship, and I kind of never looked back from there. I also went to the University of Southern California, and I studied engineering management. And most of my work has been in working with researchers like yourself to translate research into technology and then bring that to market through entrepreneurship. So that's my own background, so more on the business side. So here's my team at Moving Analytics. I thought I'd point out some of the clinicians on the team. So I work with Dr. Robert Busk and Nathan Miller, and both of them came from Stanford School of Medicine. But very quickly, our work at Moving Analytics is, like Mark said, in working with hospitals to increase the reach and the effectiveness of your secondary prevention programs for heart disease. And we currently work with some thought leaders in the country. So to go into the need for secondary prevention, I would like to tell you a story. So I'd like you to meet Joe, and Joe just suffered from a heart attack. Now, upon discharge, like many of you, his cardiologist prescribed him a cardiac rehab program, and he touted these benefits, like he has chance of dying in 3 years, and he has less chance of getting a second heart attack, and he's going to improve his quality of life. But for Joe to attend a cardiac rehab program, he would have to go to the hospital 3 times a week. And most times the hospital is very far away from home or his work. In addition, the co-pays for participating in the program are very high. It could cost up to $50 a session. So fortunately, Joe decides not to go to cardiac rehab. But Joe is not alone. In fact, in the US, less than 20% of patients would attend a cardiac rehab program, despite the mountain of evidence that it's good for them. And initially people thought that the problem was cardiologists were not referring enough patients. And so I thought I'd pull some data where you look at, when we look at referral to cardiac rehab, it's gotten to as high as 80% recently, but the participation isn't changing. And that shows that, the problem is really the current model of delivering cardiac rehab is not patient-centered, and we need to find new ways to make it more convenient for patients. So I always like to think about what the implication is. So when a patient doesn't do cardiac rehab, I think they feel the worst effect. So they're pretty much denied access to life-saving care, and they have higher risk of mortality, of getting a second event. But for health systems, before there wasn't any direct consequence for not having a cardiac rehab program or for not investing in cardiac rehab. But as we transition to value-based care models like the bundled payments, cardiac rehab would play a very big role for secondary prevention. So it's going to be very important as we go forward to really think about cardiac rehab. And as a society as a whole, the news of town right now is Medicare and the Affordable Care Act, and how healthcare costs are spiraling out of control. And when we don't have secondary prevention programs like cardiac rehab, we all get to pay for it, through taxes and through the cost of healthcare. So it's really important that we do something about this. And this is not just an opinion that I share. The AHA, the ACC, and the American Association for Cardiovascular and Pulmonary Rehab have made mandates to increase the utilization of cardiac rehab from 20% to 70%. And they published this article. It's not a paper, but it had different strategies where they talked about things programs can do to improve the attendance of cardiac rehab. And one of the things that the three things they talked about that were important was ensuring that physicians endorse cardiac rehab and give a strong message to patients during bedside or before they get discharged. The second was the idea of automated referrals, so having standing orders so that you don't have to remember to prescribe cardiac rehab, and the EMR just does it. And third was using home-based approaches to deliver cardiac rehab. So those are the three things we talked about. So I'm going to focus on the third one because that's more of my area of expertise. So now I'm going to talk about the evidence for home-based cardiac rehab. So before we go into the evidence, just to think about what the components of cardiac rehab are and how this is delivered, at home. So cardiac rehab is really focused on, risk factor modification for patients, after AMI or any acute coronary event. And the programs usually consist of exercise coaching, where patients, the goal there is to improve a patient's functional capacity. And then there's risk factor management, working with patients to help them understand what are their risks for heart disease, and working with them to reduce, to implement smoking cessation, to manage their weight, to reduce the blood pressure, and that's risk factor. Medication adherence component, where cardiac rehab programs are sort of medication reconciliation. Because they have a lot of touch points with patients, they make it a point to make sure that patients get their meds. And big part of cardiac rehab is psychosocial support, both from the clinicians that run the programs, but from other patients. For a lot of patients, I think there's studies that show that patients get depressed after a heart attack, or there's a high rate of depression. And the fact that they're in the room with other people who, are a couple of weeks into the program and have progressed very well, is very, very helpful to the patient. So that sense of community is a big support. And also, the fact that the cardiac rehab nurses or the exercise physiologists in the program can give the patients reassurance that, it's going to be fine, you're going to be fine, you can exercise, and we're going to get you back into good health. It has been a very big component of that. And, the last part of cardiac rehab is education. So, patients get educations on their risk factors and strategies to improve their health. So these are the core components of cardiac rehab. And the way it's currently delivered today is done in an hour-long class where patients come in, or a patient will come in. And in that class, they get on the treadmill for about 30 minutes, and they get like an educational class where, one of the cardiac rehab staff will give a talk. And there's a one-on-one kind of chat between the cardiac rehab team and or cardiac rehab staff and the patient. And patients have to do this, for 36 times. And the challenge, obviously, is, if you live in a big city and you have to drive, or there's traffic, or you have work, it's just impossible to do it. So a lot of research has gone into the idea of home-based cardiac rehab and how do you make it more convenient for patients. And in the home-based model, the way it worked is essentially patients come into the clinic for an initial evaluation, and they get an individualized treatment plan. And patients go home, and they go home with a workbook. And that workbook has everything from, like, education to different logs for them to log the exercise and the diet and different things like that. And patients get an instruction of the things they need to do on a given week. And the way the home-based programs typically work is the case manager or the nurse will call the patient every week and say, hey, Joe, how are you doing your exercise? How are you doing your diet? And they're asking them all these questions. So it's more of a self-managed approach to care. And there's been a lot of research that shows that, home-based cardiac rehab programs are as effective as the traditional center-based program. So this, in 2015, Cochrane Library did a review, and essentially, they said that home-based cardiac rehab are as good and as effective as center-based programs. One of the questions I always get asked a lot by physicians is home-based cardiac rehab safe for patients? Can they exercise at home? And this research shows just that it's very safe for patients. And I always go back, and what I always ask people is, would you rather 80% of people don't get access to care today, and for especially the low to moderate risk patients, there's no reason why they can exercise at home. And research shows that it's also safe for them to do that. So, but there's, when you think of this model of delivering cardiac rehab, there's been a lot of limitations that prevented it from being widely adopted. The first is the idea of objective monitoring. When patients are, writing things in logs, it's very hard. It's a lot of the data you're getting from patients are self-reported, and it's not very, objective for you to deliver a good care with. The other thing is also technology. When you think of managing hundreds or thousands of patients using a home-based model, there's lack of tools that programs need to do this effectively, because not all of them, this is more of a program management, from a program management perspective. And the third is, when you building on top of that, the quality of these programs, because they're mostly paper-based and people are running them through spreadsheets, there's a lot of variations in the quality of care. So you can have a nurse that's very great with patients and talking to them, but that may vary from different practitioners. So there's some challenges there from the quality control. But the biggest barrier to home-based cardiac rehab has been there hasn't been any financial incentive for hospitals to implement it. So typically, Medicare and private insurance have not reimbursed for home-based cardiac rehab. So while it sounds good on paper and while the evidence shows that patients have a higher uptake of home-based programs, no one does it except for health systems like Kaiser Permanente that are both the insurers and the providers, and they see the need for cardiac rehab from a cost reduction perspective. So moving into telehealth and the role for telehealth in cardiac rehab, there's been a lot of research showing that the mobile delivery of cardiac rehab is also as effective as the center-based model, and it has very high uptake rates and very high completion rates. So this is a study published in Heart. So when I started, my company, and I got introduced to this idea of cardiac rehab, there's 4 big questions. When I thought of how do you make cardiac rehab patient-centered, and the first was, it had to be evidence-based, obviously. Healthcare is all about the evidence. The second was it had to be convenient and affordable for patients. The third was it had to be cost-effective to implement, and the fourth was, we need to build a system that can scale to thousands of patients. And those are the 4 things I really thought that were important to building a program. So I started doing my research, and I was trying to find who are the thought leaders, starting with the evidence, who's done the most research in cardiac rehab or in home-based cardiac rehab. And what I found was that there was a clinical team at Stanford Medicine that had more than 20 years of research in developing and validating home-based cardiac rehab programs. So I called them and said, hey, I'm interested in learning more about the space and building technologies around this. And they were gracious to help me understand how home-based cardiac rehab worked. And what we did as a company was to license their research and use that as a foundation of our technology. So, some of the research they did was really, they started in cardiac rehab, and with the home-based model, they worked with Kaiser Permanente to do different clinical trials, and they showed, they had, improvement in functional capacity, very strong improvement in smoking cessation rates. They were able to reduce cholesterol, and they were also able to also show that their home-based model was able to reduce readmissions. And at Kaiser in Northern California, all their cardiac rehab is home-based using this model that the Stanford team had developed. So what we did was we took that research and we took all the content that they had, and then we digitized it and we've prototyped it. So I'm going to take a break and get some water. I tend to talk pretty fast. So essentially what we've done is we've taken that body of work and translated it into clinical content. This includes patient education materials, includes staff training manuals, and this is our hospital partners are free to pick and choose from our library. The second thing we provide is the technology platform, both for the patients and also for the providers to deliver this program. And then third, and more important thing we've noticed is that we provide the implementation and training support services to help hospitals really guide them through the implementation of these programs to make sure that it's a success. So everything from defining what the business model is going to be for the program to training the staff and helping them think about how to grow the program we help with. And as I said before, we're working with these different hospitals. So a lot of our work right now is split between clinical trials and clinical implementations. So with NYU, we're doing a lot of research in long-term cardiac rehab. So looking at cardiac rehab beyond 12 weeks that patients typically do, and looking, can we use telehealth, can we use mobile apps to keep patients engaged and compliant to all the things they've learned while they're in cardiac rehab. We're also doing a study with NYU in geriatric cardiology, looking at the 30-day window where it usually takes 30 days for a patient to get into a cardiac rehab program, and for geriatric patients, within those 30 days, they get debilitated. So a cardiologist by the name of Dr. Dodson at NYU is doing some research in home exercise training within those 30 days, and to see if that helps improve patients' functional status before they go into a cardiac rehab program. So that's our work with NYU. And with the Keck School of Medicine, we're doing a lot of work in home-based cardiac rehab and heart failure management. And with Mayo, we're doing a study comparing different models of cardiac rehab, where we're looking at the control is patients who go to center-based cardiac rehab, and the other arms are patients who do a hybrid of a home and center-based program using telehealth. And the third model is a completely home-based program, and we're comparing all of that to patients who don't do anything at all. So that's some of our work with the Mayo Clinic. And then with Trinity Health and VA, we're doing more of clinical implementations to help them get more patients with cardiac rehab. So that's some of our work. But I think the biggest innovation we've come across with working with our partners is really not in the technology, but it's in this idea of different models for patient-centered care. And so there's three that we've found through our work, and they're called the hybrid, population, and the engagement models of cardiac rehab. And I'll explain them to you very soon. So in the hybrid is designed more for hospitals that have an established cardiac rehab program. So you have the facility-based program. And the goal there is that patients will do the first 2 to 3 weeks of cardiac rehab in the center. And once the clinical team is comfortable with the patients exercising at home, they reduce the number of center-based sessions that patients do. So a patient goes from exercising in the clinic 3 times a week to coming maybe once a week or once every other week, and they do the rest of the program at home. So the idea of the hybrid is that there's still some face-to-face interaction, but it's a more convenient and affordable program for the patients. And what we found is that this really helps cardiac rehab programs get more patients, because now instead of telling a patient that you have to come in 3 times a week, you can stay once every other week. So that's been very successful for people who have a physical program. The second model is truer to the Stanford model, where we call it the population model. In the population model, it's more of a completely home-based program. So in this model, patients come in for an initial evaluation, and they do a 6-minute walk test or a stress test. And after that, they get an individualized treatment plan, and they get an app, and they go home with the app. And once a week, while their patients are home, the app guides them on all the things they need to for their cardiac rehab, like the exercise, tracking their different vital signs. It provides education for them. And once a week, a nurse from the cardiac rehab program will call the patients to discuss their program and how they're doing, and address any challenges patients have with keeping up. So that's the population model. I think the beauty of the population model is its cost effectiveness. So essentially, with technology, one case manager can manage up to 300 patients a year. So that makes it very, very cheap and affordable to implement a home-based program. So that's the population model. And the third model is what we call the engagement model. And this is more of a self-management program. And it's really designed for patients who've done a cardiac rehab program already, or done the hybrid population model. And in this model, patients are self-managing their care. So they get a care plan, and they're literally using an app to to track the vital signs and exercise, but they're still getting remote monitoring from the cardiac rehab team. So in this model, there's no intensive, follow-up phone calls, but it's more of if a patient needs help or they have a question, they can call into the cardiac rehab team, and that's how the engagement model works. So these are the three models we found that has really worked with different hospitals that either have an established program or don't have a program, and they've been very, very successful with patients. So, from our implementations across the board, we're showing that, if you were to offer these models, we have 60% of patients actually, do cardiac rehab. So I mean, 60% of patients that you offer the program would accept it and participate, and 80% of them finish the program. And on average, patients are exercising 118 minutes a week, and they have 90% satisfaction for the program. And I think that this is really being because of these models are more tailored to their lifestyles, and that's why we have this kind of engagement. So a lot of I think a lot of questions people have is what's the ROI, what's the business model for cardiac rehab? So I thought I'd share different models that may interest you. So in looking at the different models, so obviously the typical cardiac rehab is the traditional model, and we talked about the hybrid and population. So for Medicare and fee-for-service, hospitals that are, paid through the private insurance, there's no direct reimbursement for home-based cardiac rehab. And essentially with the hybrid model, so the idea is how do you get more patients into more sessions and, get revenue from there. So with the hybrid model, patients are attending 12 sessions on average, and that program is typically marketed towards those 80% of patients who don't do cardiac rehab. So looking at patients who get, for example, a PCI, which are usually, younger patients, and they go back to work. The hybrid model, has its own business model by, trying to get them to come to more sessions. The population model is the most convenient for patients, but it has the least revenue in a Medicare fee-for-service environment. But there's some new laws, especially in Minnesota, that actually I think may be interesting to you. So I was looking this up last night. So there's precedent for, there's federal law requires that in different states, if providers can show that they can deliver a service to telehealth with the same quality as a face-to-face visit, that private payers need to reimburse at the same rate. And Minnesota is actually one of the states that have parity laws. So essentially, the way it works is that you would have to meet with your insurance providers and say, hey, we want to offer this service to patients, and the law states that we need to get paid for this service at the same rate. And then with the health insurance provider, you agree on how to document the service, what does telemedicine mean. So for some states, telemedicine means that continuous synchronous audio, so it could just be a phone call. And for some states, it's a phone call plus video. So different states have different definitions of telehealth. So essentially, this is one way where home-based programs can be reimbursed through telehealth laws. And then I think the biggest opportunity for secondary prevention programs is this idea that we're moving to value-based payments, and we're moving away from fee-for-service. And in value-based payments, the popular model right now, or Medicare announced late last year, payments are going to be bundled. And essentially, the idea of a bundled payment is that the hospital gets one check, and they have to fit all the care, and they're responsible for 90-day readmissions. So when you think of what's happening today, 30-day readmissions for most hospitals is 20%. And if you were to extrapolate that to 90 days, then the cost, from a readmission perspective to a hospital could be very significant. So a lot of hospitals are looking at cardiac rehab, and essentially this idea of home-based cardiac rehab as a way to really get more patients to cardiac rehab, and using that as a tool to reduce readmissions. And I think that value-based care delivery models like bundles are going to play a very strong role in catalyzing that. I think it's going to be interesting to see how the new announcement plays out with the new administration, if they're going to keep it or not. So that's one driver for this. So to just wrap up with some final thoughts, I'd like to go back to Joe and tell you a different story for Joe using this new model of patient-centered care. So essentially, so Joe, once again, gets referred to cardiac rehab by his cardiologist. But now when Joe goes to the clinic, his clinical team tells him that he can do this completely from home. So at home, at the clinic, his nurse creates a care plan for him and sends him home with an app. And that care plan is created through this dashboard. Now at home, the app guides Joe through his exercise, has him log in his vital signs, provides him education, and an easy-to-use interface for him to communicate with the cardiac rehab team. As Joe completes his different tasks, his progress is sent back to the nurse on the dashboard. Once a week, his nurse calls him and checks in on him and his progress, and makes sure that he doesn't have any problems keeping up with the program. So essentially, using this model, Joe doesn't have to go to the clinic as often as he would go, and the program is also more affordable for him because he doesn't have to pay a lot of copays. And in return for doing this, the hospital gets to improve their quality measures and reduce readmissions, and this is just a more better approach for him. And this is some of the benefits. So I always like to end this talk whenever I give it by sharing why this is important to me. So when you look at the research, it shows that patients who do cardiac rehab live 5 years longer on average. And I want you to pause and think of what does 5 years mean to you. How many more birthdays, how many more anniversaries, how many more opportunities do you get to say, I love you? The fact that 80% of patients don't have access to this life-saving care is unacceptable. And that's why at Moving Analytics, we've made it our mission to build tools to ensure that patients like Joe have access to a convenient access to healthcare and make sure that they can live a longer, healthier, and productive life. So it's really been an honor to be here and share my experience with you, and I really look forward to collaborating with you to bring this vision to reality. So thank you, and I'll be happy to answer any questions.
Any questions at all?
Is there any integration with Fitbits and other means of measuring compliance?
Yes. So yes, we work with the Apple Watches and the Fitbits and the different Bluetooth scales and blood pressure cuffs. We can integrate that into the technology so that you can collect that data easily for patients.
Yeah, can you talk, I guess, a little bit more about the objective data that you're able to get? So you can get blood pressure, you can get...
Yeah, so you can track exercise and you can track heart rate. The different devices can provide that information. You can measure the weight using a Bluetooth scale, the blood pressure, the O2 saturation. So those are the 3 data points where we're collected. We have patients manually report, if they smoke and how many cigarettes they smoke. That's another data point we collect from patients. And we can also collect blood glucose for patients who have a diabetic comorbidity. Any other questions?
Any other questions at all? All right, thanks, Ade.
Thank you, everyone. Thank you.
Wonderful. Thanks for coming again.
You're welcome.
Hey, Steve. All right. Good, glad you're here.